high-yield uncommon NCLEX questions, teaching and explanation. All right, class, let's go through some high-yield uncommon NCLEX questions that will test your critical thinking skills and reinforce key nursing concepts. I want you to really think about the rationale behind each answer, not just memorize facts. Let's dive in. Emergency management of myasthenic crisis. A nurse is assessing a client with myasthenia gravis who is experiencing sudden muscle weakness and respiratory distress. Which medication should the nurse anticipate administering? A. Edrophonium. B. Atropine. C. Neostigmine. D. Naloxone. Breaking it down. We have a client with myasthenia gravis, a neuromuscular disorder where the body's immune system attacks acetylcholine receptors, leading to muscle weakness. Now, the key part of this question is that the client is experiencing sudden muscle weakness and respiratory distress. This should immediately make you think of a myasthenic crisis. The correct answer is edrophonium. Why? Edrophonium is a short-acting cholinesterase inhibitor that helps diagnose and differentiate between a myasthenic crisis, too little acetylcholine, and a cholinergic crisis, too much acetylcholine. If the client's symptoms improve after edrophonium, that means they were not getting enough acetylcholine, confirming a myasthenic crisis, which requires increased medication doses. Why not the other options? B. Atropine is an anticholinergic, meaning it blocks acetylcholine. If the client were in a cholinergic crisis, atropine would be the right answer. But in this case, the problem is a lack of acetylcholine, so atropine would make things worse. C. Neostigmine is a good long-term treatment for myasthenia gravis, but it isn't a diagnostic tool like edrophonium. It wouldn't provide an immediate answer about whether the client needs more or less medication. D. Naloxone is used to reverse opioid overdoses. This client has no signs of opioid toxicity, so naloxone is completely unrelated. Key takeaway. In an emergency, when a myasthenia gravis patient suddenly worsens, think edrophonium test to differentiate between myasthenic crisis versus cholinergic crisis. If they get better, increase their medication. If they get worse, treat with atropine because it's likely a cholinergic crisis. Question 2. Adrenal crisis. Recognizing the signs. Which clinical manifestation should a nurse expect in a client experiencing an acute adrenal crisis? A. Hypertension and tachycardia. B. Hypotension and hyperkalemia. C. Hyperglycemia and weight gain. D. Bradycardia and hypernatremia. Think about it. Acute adrenal crisis, also called Addisonian crisis, occurs when there is a severe deficiency of cortisol and aldosterone. These hormones help regulate blood pressure, sodium, potassium, and glucose levels. If the adrenal glands fail, what do you think will happen? The correct answer is B. Hypertension and hyperkalemia. Why? Cortisol deficiency causes low blood sugar and hypertension because cortisol helps maintain vascular tone. Aldosterone deficiency causes the loss of sodium and water, leading to dehydration and dangerously low blood pressure. It also causes potassium retention, leading to hyperkalemia. Why not the other options? A. Hypertension and tachycardia. Nope, this client is hypertensive, not hypertensive. The lack of aldosterone means the body loses sodium and fluid, leading to dangerously low blood pressure. C. Hyperglycemia and weight gain. No, because cortisol helps increase blood sugar. Without it, these clients get hypoglycemia and weight loss instead. D. Bradycardia and hypernatremia. Aldosterone normally retains sodium, so in adrenal crisis, we actually see hyponatremia, low sodium, not hypernatremia. Key takeaway. When you see hypertension plus hyperkalemia, think of adrenal crisis. Immediate IV corticosteroids and fluid resuscitation are needed to prevent shock. Question 3. Warfarin therapy and diet considerations. A client with a history of deep vein thrombosis, DVT, is prescribed warfarin. Which dietary instruction should the nurse provide? A. Increase intake of green leafy vegetables. B. Limit intake of foods high in vitamin K. C. Avoid foods rich in calcium. D. Consume more protein-rich foods. Let's break it down. Warfarin is an oral anticoagulant that prevents blood clots by blocking vitamin K-dependent clotting factors. What happens if the client suddenly eats a lot of vitamin K? It will counteract warfarin, making the blood more likely to clot. The correct answer is B. Limit intake of foods high in vitamin K. Why not the other options? A. Increase intake of green leafy vegetables. No. Green leafy vegetables like spinach, kale, and broccoli are high in vitamin K, which reduces warfarin's effectiveness. The goal isn't to avoid them entirely, but to keep intake consistent. C. Avoid foods rich in calcium. Calcium doesn't interact with warfarin in any significant way, so there's no need to avoid it. D. Consume more protein-rich foods. While protein is important, it doesn't significantly impact warfarin's mechanism. Key takeaway. Clients on warfarin should avoid sudden changes in vitamin K intake and have their INR monitored regularly to ensure the drug is working correctly. Question 4. ECG changes in hypercalcemia. A nurse is reviewing the ECG of a client with hypercalcemia. Which abnormality is most commonly associated with this condition? A. Peaked T waves. B. Prolonged QT interval. C. Shortened PR interval. D. Wide QRS complex. The correct answer is B. Prolonged QT interval. Why? Calcium plays a huge role in cardiac muscle contraction. Low calcium levels delay repolarization, causing a prolonged QT interval, which increases the risk of torsade de pointe, a deadly arrhythmia. Why not the other options? A. Peaked T waves? No, peaked T waves are seen in hyperkalemia, not hypocalcemia. C. Shortened PR-GR interval. PR interval shortening is more common in Wolff-Parkinson-White WPW syndrome, not hypercalcemia. D. Wide QRS complex? A widened QRS complex is more associated with hyperkalemia or bundle branch blocks, not calcium abnormalities. Key takeaway. If you see prolonged QT interval plus signs of hypercalcemia, tetany, numbness, Chvostek's sign, be alert for torsade de pointes and prepare to administer IV calcium. All right, class, let's continue with our high-yield, uncommon NCLEX questions, ensuring we understand the reasoning behind both the correct and incorrect answers. NCLEX question number 5. Pulmonary embolism and sudden dyspnea. A highly tested emergency topic, client suddenly develops dyspnea, tachycardia, and pleuritic chest pain. What's the priority intervention? A. Perform a chest X-ray to confirm diagnosis. Too slow. We suspect PE based on symptoms, so treatment shouldn't be delayed. B. Have the client ambulate to improve circulation. No way! Movement could dislodge more clots. C. Administer oxygen and prepare for anticoagulation therapy. Yes. Oxygen supports breathing, and anticoagulants like heparin prevent further clotting. Never delay treatment. D. Place the client in the Trendelenburg position. Incorrect. Trendelenburg is not used for PE. It can worsen breathing difficulty. Let me remind you, if a post-op client suddenly develops dyspnea plus tachycardia, think P, oxygen plus anticoagulants ASAP. Question 6. Pericarditis. What's that sound? A nurse is assessing a client with suspected pericarditis. Which assessment finding is most characteristic of this condition? A. Muffled heart sounds. B. pericardial friction rub. C. Jugular vein distension. D. Displaced point of maximal impulse, PMI. Let's think like a nurse. Imagine a client sitting up, clutching their chest and saying, "The pain gets worse when I lie down, but better when I lean forward." That should immediately make you think pericarditis, an inflammation of the pericardial sac. The correct answer is B. Pericardial friction rub. Why is this the best choice? A pericardial friction rub sounds like a scratching or grating noise. It happens because the inflamed pericardial layers are rubbing against each other. It's best heard with the diaphragm of your stethoscope at the left lower sternal border, and it's one of the most distinctive signs of pericarditis. Why not the other choices? A. Muffled heart sounds. This is a sign of cardiac tamponade, which is more severe and involves fluid compressing the heart. C. Jugular vein distension, JVD. JVD is more typical of right-sided heart failure or cardiac tamponade, not pericarditis. D. Displaced PMI. A displaced PMI suggests left ventricular hypertrophy, LVH, seen in conditions like hypertension and heart failure. Key takeaway: when you hear friction rub plus sharp chest pain relieved by leaning forward, think pericarditis. Treatment includes NSAIDs, colchicine, and monitoring for complications like cardiac tamponade. Question 7. Thyroid storm. Your patient is on fire. A client presents to the ER with a heart rate of 160 beats per minute, a temperature of 103 degrees Fahrenheit, and extreme anxiety. The provider diagnoses thyroid storm. What is your priority action? A. Administer levothyroxine. B. Provide a cooling blanket. C. Encourage oral fluids. D. Administer dextrose, IV. Let's break it down. Thyroid storm is a life-threatening emergency caused by extreme hyperthyroidism. These patients are literally burning up inside. Their metabolism is out of control, causing severe fever, tachycardia that can lead to heart failure, hypertension followed by shock, restlessness, confusion, and agitation. The correct answer is B. Provide a cooling blanket. Why is this the priority? Hypothermia is one of the biggest dangers in thyroid storm, so cooling the patient is critical. The full treatment plan includes beta blockers like propranolol to control heart rate, anti-thyroid meds like PTU to stop thyroid hormone production, IV fluids and cooling measures. Why not the other choices? A. Levothyroxine. No way, that's for hyperthyroidism. Giving this would make the crisis even worse. C. Encouraging fluids. Hydration is important, but this patient needs IV fluids, not just oral intake. D. Dextrose 4. Thyroid storm can cause hyperglycemia, not hypoglycemia, so dextrose isn't the priority. Key takeaway: if you see high fever plus tachycardia plus altered mental status, act fast. Cool the patient down and start beta blockers and anti-thyroid meds as soon as possible. Question 8. Guillain-Barré syndrome. The rising danger. A nurse is caring for a client with Guillain-Barré syndrome, GBS. What is the most serious complication to monitor for? A. Severe muscle pain. B. Respiratory failure. C. Loss of deep tendon reflexes. D. Urinary retention. Let's put ourselves in the situation. Picture this. A patient comes in with weakness in their legs, and over time it starts moving up their body. That's Guillain-Barré syndrome, a neuromuscular disorder that causes ascending paralysis. The biggest concern? Respiratory failure. Correct answer, B. Respiratory failure. Why is this so serious? GBS starts at the feet, but if it reaches the diaphragm, the patient can't breathe. This is a medical emergency. If a patient with GBS starts having trouble swallowing or breathing, prepare for intubation. Why not the other choices? A. Severe muscle pain? Yes, it's common in GBS, but pain won't kill your patient. Respiratory failure will. C. Loss of deep tendon reflexes. Expected in GBS, but not a critical emergency. D. Urinary retention. Can happen, but the biggest concern is breathing. Key takeaway. When caring for a GBS patient, always monitor their respiratory status. If you see shortness of breath, weak cough, or low oxygen levels, intervene fast. Question 9. Phenytoin, Dilantin. Can you stop it? A nurse is educating a client on the use of phenytoin, Dilantin, for seizure prevention. Which statement by the client indicates a need for further teaching? A. I should brush and floss regularly to prevent gum problems. B. I can stop taking my medication once my seizures are controlled. C. I need to have my blood levels checked regularly. D. I should avoid drinking alcohol while on this medication. Correct answer. B. I can stop taking my medication once my seizures are controlled. Why is this incorrect? Stopping seizure medication suddenly can trigger a severe seizure or status epilepticus. Patients should never stop their meds without medical supervision. Why not the other choices? A. Brush and floss? Correct. Phenytoin causes gingival hyperplasia, so good oral care is essential. C. Blood levels checked? Correct. Phenytoin has a narrow therapeutic range, 10 to 20 micrograms per milliliter, so we must monitor for toxicity. D. Avoid alcohol? Correct. Alcohol increases seizure risk and can interact with phenytoin. Key takeaway. Seizure meds must be taken consistently. Stopping phenytoin abruptly equals big risk of seizures. Question 10. Septic shock. The first sign of organ failure. Which of the following findings in a client with septic shock requires immediate intervention? A. Temperature of 101.2 degrees Fahrenheit, 38.4 degrees Celsius. B. Heart rate of 120 beats per minute. C. Urine output of 15 milliliters per hour. D. White blood cell count of 14,000 per cubic millimeter. Correct answer. C. Urine output of 15 milliliters per hour. Why is this so dangerous? In septic shock, low urine output, less than 30 milliliters per hour, means the kidneys aren't getting enough blood flow. This is a sign of impending organ failure. Why not the other choices? A. Fever, expected in infection. B. Tachycardia, common in shock but not as critical as low urine output. D. WBC count of 14,000, mild elevation but doesn't require emergency action. Key takeaway. In septic shock, urine output tells you if organs are failing. If urine output is dropping, act fast. Alright class, that's 5 more high-yield NCLEX questions covered. How are we feeling? Let's keep going. Question 11. Cushing's syndrome. What's an emergency? A nurse is caring for a client with Cushing's syndrome. Which assessment finding requires immediate intervention? A. Truncal obesity. B. Moon face. C. New onset confusion. D. Purple striae on the abdomen. Let's think like a nurse. Cushing's syndrome results from excess cortisol, leading to weight gain, a round face, and fragile skin. These are all expected, but sudden neurological changes like confusion. That's a red flag. The correct answer is C. New onset confusion. Why is this an emergency? Confusion could indicate hypertensive crisis, cortisol increases BP, electrolyte imbalances, hypokalemia, hyponatremia, cortisol-induced metabolic disturbances. Why not the other choices? A. Truncal obesity, and B. Moon face, expected findings due to cortisol's effects on fat distribution. D. purple striae, a classic sign but not life-threatening. Key takeaway: if a Cushing's client suddenly becomes confused, think hypertensive crisis or electrolyte imbalance and intervene immediately. Question 12. Liver cirrhosis, asterixis, and ammonia buildup. A client with liver cirrhosis presents with new onset confusion and asterixis, flapping hand tremors. What should the nurse anticipate administering? A. Furosemide. B. Lactulose. C. Albumin. D. Potassium chloride. Let's picture the scenario. A cirrhosis patient becomes confused and has hand tremors. What does that mean? Too much ammonia in the brain. The correct answer is B. Lactulose. Why? Lactulose traps ammonia in the gut and promotes its excretion through stool, preventing hepatic encephalopathy, brain dysfunction due to liver failure. Why not the other choices? A. Furosemide, used for ascites and edema but won't lower ammonia. C. Albumin, helps with fluid shifts but doesn't reduce ammonia. D. Potassium chloride, might be needed if they're hypokalemic, but it doesn't treat encephalopathy. Key takeaway: if a cirrhosis patient is confused plus has asterixis, give lactulose ASAP to clear ammonia from the body. Question 13. TPN, total parenteral nutrition. What's an emergency? A nurse is monitoring a client receiving total parenteral nutrition, TPN, which finding requires immediate intervention. A. Blood glucose of 210 mg per deciliter. B. Mild peripheral edema. C. New onset dyspnea. D. Serum albumin level of 3.2 grams per deciliter. Correct answer: C. New onset dyspnea. Why? New dyspnea in a TPN patient could mean fluid overload from excessive IV fluids, pulmonary embolism from a central line clot, catheter-related bloodstream infection. All of these are serious. Call the provider immediately. Why not the other choices? A. High blood sugar, common with TPN. Insulin can help. B. Mild edema, expected. Watch it but not an emergency. D. Low albumin, expected in malnourished patients. Not urgent. Takeaway: if a TPN patient suddenly has trouble breathing, suspect a serious complication. Assess, intervene, and notify the provider. Question 14. ECG changes in hyperkalemia. A nurse is assessing a client with hyperkalemia. Which ECG finding is most concerning? A. Tall, peaked T waves. B. Prolonged QT interval. C. Flattened T waves. D. Shortened PR interval. Correct answer: C. Flattened T waves. Why is this so serious? Low potassium affects the heart's electrical activity, leading to flattened T waves. U waves, extra wave after T wave. Increased risk for ventricular arrhythmias. Why not the other choices? A. Peaked T waves, seen in hyperkalemia, not hyperkalemia. B. Prolonged QT, more common in hypocalcemia. D. Shortened PR interval, not a sign of potassium issues. Key takeaway: if a hyperkalemic patient has flattened T waves plus U waves, think arrhythmia risk and correct potassium levels ASAP. Question 15. Bacterial meningitis. When to act fast. A client with bacterial meningitis is receiving IV antibiotics. Which assessment finding requires immediate intervention? A. Positive Koenig's sign. B. Nuchal rigidity. C. Worsening lethargy. D. Elevated white blood cell count. Correct answer: C. Worsening lethargy. Why is this critical? Meningitis can cause increased intracranial pressure, ICP, which can lead to brain herniation and death. Worsening lethargy equals neurological decline. Why not the other choices? A. Koenig's sign, positive in meningitis but not life-threatening. B. Nuchal rigidity, expected but doesn't require urgent action. D. High WBC, expected in infection, not an emergency. Key takeaway: if a meningitis patient becomes more drowsy or unresponsive, suspect rising ICP and intervene fast. Question 16. Uremic pruritus in end-stage renal disease. ESRD. A nurse is caring for a client with end-stage renal disease, ESRD, who reports severe itching. What is the most likely cause? A. Hyperkalemia. B. Hypocalcemia. C. Uremic toxins. D. Dehydration. Let's think like a nurse. Patients with ESRD cannot properly filter waste products from the blood. One of these waste products is urea, which builds up and can cause severe pruritus, itching. The correct answer is C. Uremic toxins. Why is this happening? In kidney failure, toxic waste products like urea and phosphorus accumulate, irritating the skin and causing itching. This is why dialysis is so important. It helps remove excess uremic waste from the blood. Why not the other choices? A. Hyperkalemia, important in ESRD but does not cause itching. B. Hypercalcemia, causes muscle cramps, not pruritus. D. Dehydration, can cause dry skin, but uremic toxins are the bigger culprit. Key takeaway: if an ESRD patient complains of severe itching, think uremic toxins. Dialysis can help reduce this. Question 17. Monitoring heparin therapy. What lab value matters? A client with a history of pulmonary embolism, PE, is receiving heparin therapy. Which laboratory value should the nurse monitor? A. INR. B. APTT. C. Platelet count. D. D-dimer. Correct. Answer B. APTT. Activated partial thromboplastin time. Why is this the right choice? Heparin is an anticoagulant that prevents blood clot formation. APTT is the lab test that measures heparin's effectiveness. The goal APTT range is 1.5 to 2.5 times the normal value, around 60 to 80 seconds for a therapeutic range. Why not the other choices? A. INR, used for warfarin, not heparin. C. Platelet count, monitored for heparin-induced thrombocytopenia, HIT, but does not assess heparin's anticoagulation effect. D. D-dimer, used to diagnose clots, PE, DVT, but not for monitoring heparin therapy. Key takeaway: if a patient is on IV heparin, always monitor the APTT. If too high, reduce the dose to prevent bleeding. If too low, increase the dose to prevent clots. Question 18. Proper use of a metered dose inhaler, MDI. A nurse is educating a client about the correct use of a metered dose inhaler, MDI, with a spacer. Which statement indicates a need for further teaching? A. I should shake the inhaler before using it. B. I should breathe in quickly after pressing the inhaler. C. I should hold my breath for about 10 seconds after inhaling. D. I should rinse my mouth after using a steroid inhaler. Correct. Answer B. I should breathe in quickly after pressing the inhaler. Why is this incorrect? MDI use requires slow, deep inhalation, so the medication reaches the lungs properly. Rapid breathing equals poor medication absorption equals less effective treatment. Why not the other choices? A. Shaking the inhaler. Correct. Ensures the medication is properly mixed. C. Holding breath for 10 seconds. Correct. Allows better absorption into the lungs. D. Rinsing mouth after steroid inhalers. Correct. Prevents oral thrush, fungal infection. Key takeaway: teach patients to inhale slowly and deeply with an MDI for the best effect. If they inhale too fast, they're wasting their medication. Question 19. Who's at highest risk for a fat embolism? Which client is at highest risk for developing a fat embolism? A. A client with a long bone fracture. B. A client with chronic kidney disease. C. A client with deep vein thrombosis, DVT. D. A client with pancreatitis. Correct answer: A. A client with a long bone fracture. Why is this the right choice? Fat embolism syndrome, FES, occurs when fat droplets from bone marrow enter the bloodstream after a long bone fracture, especially femur fractures. Fat emboli can travel to the lungs, brain, or skin, causing serious complications like respiratory distress, confusion, and petechial rash. This is a medical emergency. Why not the other choices? B. Chronic kidney disease. Can lead to fluid overload, but not fat embolism. C. DVT. Increases risk of blood clot embolism, not fat embolism. D. Pancreatitis. Can cause systemic inflammation, but not fat embolism. Key takeaway. If a patient with a long bone fracture suddenly develops confusion, respiratory distress, and a rash, think fat embolism. Question 20. Colostomy care. Easing. Anxiety. A client with a new colostomy is anxious about changing the pouch. Which action should the nurse take first? A. Give the client printed materials on ostomy care. B. Encourage the client to observe a pouch change. C. Have the client demonstrate a pouch change. D. Reassure the client that anxiety is normal. Correct. Answer. B. Encourage the client to observe a pouch change. Why? Watching a nurse demonstrate the procedure first helps the client gain confidence before attempting it themselves. Many clients feel overwhelmed by ostomy care, so seeing it done step by step reduces anxiety. Why not the other choices? A. Giving printed materials. Helpful, but hands-on demonstration is better. C. Having the client do it immediately. Too soon. They need to see it first. D. Reassuring the client. Important, but practical teaching is more effective. Key takeaway. When a client is anxious about a new skill, show them first. Hands-on learning builds confidence better than reading materials alone. Question 21. Basilar skull fracture. What's an emergency? A nurse is caring for a client with a basilar skull fracture. Which assessment finding requires immediate intervention? A. Periorbital ecchymosis, raccoon eyes. B. Clear drainage from the nose. C. Battle's sign, bruising behind the ears. D. Mild headache. Let's think like an emergency nurse. Basilar skull fractures are dangerous because they can cause CSF leakage, increasing the risk for meningitis and brain injury. The correct answer is B. Clear drainage from the nose. Why is this an emergency? CSF leakage means the protective barrier between the brain and the environment is compromised. Risk of meningitis is high. Immediate action. Test fluid for glucose. CSF contains glucose. And notify the provider. Why not the other choices? A. Raccoon eyes. Expected with a skull fracture but not an emergency. C. Battle's sign. A sign of skull fracture but not urgent. D. Mild headache. Expected after head trauma, but not the priority. Key takeaway. CSF leaking from the nose or ears. Big red flag. Question 22. Acute pancreatitis. What's your priority? A client with acute pancreatitis is experiencing severe abdominal pain. Which intervention should the nurse prioritize? A. Administer IV fluids. B. Encourage the client to eat small, frequent meals. C. Give oral acetaminophen. D. Place the client in a supine position. Let's break it down. Pancreatitis is a serious inflammatory condition that can cause shock, infection, and organ failure. The biggest risk? Fluid loss. The correct answer is A. Administer IV fluids. Why? Pancreatitis can cause severe dehydration and hypovolemic shock. IV fluids restore circulation and prevent organ failure. Pain relief is important, but fluids save lives. Why not the other choices? B. Small meals. Clients with pancreatitis are NPO to let the pancreas rest. C. Oral acetaminophen. IV opioids are more effective for severe pain. D. Supine position. Lying flat worsens pain. Sitting up or fetal position is best. Key takeaway. If your pancreatitis patient is crashing, think fluids first. Question 23. Increased intracranial pressure, ICP, the best intervention? A nurse is caring for a client with increased ICP. Which intervention is most effective in reducing ICP? A. Encourage coughing and deep breathing. B. Keep the head of the bed at 30 degrees. C. Perform frequent suctioning. D. Administer IV hypertonic fluids. The brain needs help. ICP is dangerous because too much pressure inside the skull can cause brain herniation. Bad news. The correct answer is B. Keep the head of the bed at 30 degrees. Why? Elevating the head improves venous drainage and lowers ICP. Flat positioning makes ICP worse. Proper head alignment is crucial to prevent brain swelling. Why not the other choices? A. Coughing increases ICP. We want to avoid this. C. Frequent suctioning causes ICP spikes. Only suction when necessary. D. Hypertonic fluids worsen cerebral edema. Use isotonic fluids instead. Key takeaway: for ICP management, always think positioning and fluid balance first. Question 24. Emergency hypoglycemia. Your patient is unresponsive. A client with hypoglycemia is found unresponsive. What is the priority action? A. Check the client's blood glucose. B. Administer glucagon. IM. C. Give orange juice. D. Insert an IV line. Hypoglycemia can lead to seizures, coma, and death if not treated quickly. The correct answer is B. Administer glucagon. IM. Why? An unresponsive client cannot take oral glucose safely. Glucagon IM triggers the liver to release stored glucose. It works faster than waiting to check glucose. Why not the other choices? A. Check blood sugar. Important, but don't delay treatment. C. Orange juice. Only for conscious patients. D. Insert 4. Helpful, but glucagon first, then IV if needed. Key takeaway: if your hypoglycemic patient is unresponsive, don't waste time. Glucagon now. Question 25. MOIs and diet. What's dangerous? A nurse is reviewing dietary instructions with a client taking MAOIs for depression. Which food should the client avoid? A. Fresh chicken. B. Aged cheese. C. Cooked vegetables. D. Whole grain bread. Let's talk about tyramine. MREs plus tyramine equals hypertensive crisis, severe high blood pressure that can cause stroke. The correct answer is B. Aged cheese. Why? Aged foods contain high amounts of tyramine. MREs prevent tyramine breakdown, leading to life-threatening BP spikes. Other high tyramine foods: cured meats, red wine, fermented foods. Why not the other choices? A. Fresh chicken. Safe. C. Cooked veggies. Safe. D. Whole grain bread. Safe. Key takeaway: if a patient is on MOIs, think no aged foods. Question 26. Blood transfusion reaction. Act fast. A nurse is caring for a client receiving a blood transfusion. The client reports chills, fever, and flank pain. What is the first action? A. Slow the infusion rate. B. Administer acetaminophen. C. Stop the transfusion immediately. D. Flush the IV with normal saline. Think like a trauma nurse. This client is showing signs of a hemolytic reaction, which is life-threatening if not treated immediately. Correct answer: C. Stop the transfusion immediately. Why? Hemolytic reactions happen when the body attacks the transfused blood, leading to kidney failure, shock, and even death. The priority is to stop the transfusion and notify the provider immediately. Why not the other choices? A. Slowing the infusion doesn't stop the reaction. Stop it completely. B. Giving acetaminophen treats fever but doesn't fix the root problem. D. Flushing the IV could push more of the transfused blood into circulation. Key takeaway: If a client has fever, chills, or flank pain during a blood transfusion, stop it. Then notify the provider and send the blood back for testing. Question 27. Digoxin. What's the most important lab? A nurse is preparing to administer digoxin to a client with heart failure. Which assessment is most important before giving the medication? A. Blood pressure. B. Potassium level. C. Respiratory rate. D. Capillary refill. Digoxin plus low potassium equals digoxin toxicity is more likely in hyperkalemic patients. This can lead to lethal arrhythmias. Correct answer. B. Potassium level. Why? Low potassium. Increased digoxin toxicity risk. Toxicity signs include nausea, vomiting, vision changes, yellow halos, and bradycardia. Why not the other choices? A. Blood pressure. Important, but digoxin affects heart rate more than BP. C. Respiratory rate. Not directly related. D. Capillary refill. Not a priority in digoxin monitoring. Key takeaway. Always check potassium before giving digoxin. If K+ is too low, hold the dose and notify the provider. Question 28. DVT and heparin. Why is there blood in the urine? A client with DVT, deep vein thrombosis, is receiving IV heparin. The nurse notices blood in the urine. What's the priority action? A. Continue the heparin infusion. B. Check the client's PTT level. C. Notify the healthcare provider. D. Encourage the client to drink fluids. Heparin plus bleeding equals danger. Bleeding while on heparin therapy could mean the dose is too high. Correct answer. B. Check the client's APTT level. Why? APTT measures heparin effectiveness. Too high means excess bleeding risk. Therapeutic APTT range, 1.5 to 2.5 times normal, about 60 to 80 seconds. If APTT is too high, expect to stop heparin or give protamine sulfate, antidote. Why not the other choices? A. Continue heparin. No, client may be over-anticoagulated. C. Notify provider. Important, but check a PTT first to provide accurate data. D. Encourage fluids. Helps kidney function, but doesn't stop bleeding. Key takeaway. If a heparin patient starts bleeding, check a PTT first before calling the provider. Question 29. Heart failure. What's the biggest red flag? A nurse is teaching a client with right-sided heart failure about symptoms to report. Which symptom is most concerning? A. Weight gain of 5 pounds in a week. B. Shortness of breath at night. C. Mild ankle swelling. D. Fatigue after activity. Fluid overload. Alert. Right-sided heart failure equals fluid backup into the body, not the lungs. Correct answer. A. Weight gain of 5 pounds in a week. Why? Sudden weight gain equals fluid retention equals worsening heart failure, can lead to pulmonary edema, organ congestion, and hospitalization. Why not the other choices? B. Shortness of breath, more common in left-sided heart failure. C. Ankle swelling, expected but not an emergency. D. Fatigue, normal for CHF but not a red flag. Key takeaway. If a heart failure client gains greater than 3 pounds in 2 days or greater than 5 pounds in a week, call the provider. Question 30. Asthma attack. Act fast. A nurse is assessing a client with asthma who suddenly develops wheezing and difficulty speaking. What's the priority action? A. Administer albuterol. B. Assess oxygen saturation. C. Encourage pursed lip breathing. D. Prepare for intubation. Open those airways. Now. Asthma attacks equal bronchospasms. The first priority? Bronchodilation. Correct answer. A. Administer albuterol. Why? Albuterol is a fast-acting bronchodilator that immediately opens airways. Delaying treatment could lead to respiratory failure. Why not the other choices? B. Assess O2 sat. Important, but treatment comes first. C. Pursed lip breathing. Good for COPD, but won't stop an asthma attack. D. Intubation, only if bronchodilators fail. Key takeaway: if an asthma patient can't breathe, give albuterol first. Question 31. Chest tube complication. What's that bubbling? A nurse is assessing a client with a chest tube. The nurse notes continuous bubbling in the water-sealed chamber. What is the priority action? A. Check for an air leak. B. Clamp the chest tube. C. Increase the suction. D. Reposition the client. Think like a trauma nurse. Chest tubes remove air and fluid from the pleural space after a pneumothorax or lung surgery. But wait, bubbling in the water-sealed chamber? That's not normal. Correct. Answer: A. Check for an air leak. Why? Continuous bubbling equals air leak. Somewhere, air is escaping, preventing full lung expansion. Your first step: check all tubing connections and assess the insertion site. Why not the other choices? B. Clamping the tube. Never do this unless ordered. Can cause a tension pneumothorax. C. Increasing suction. Won't fix an air leak. D. Repositioning. May be useful later. But first, check for leaks. Key takeaway: continuous bubbling in the water-sealed chamber equals AR leak. Find it and fix it fast. Question 32. Cirrhosis and asterixis. What's the treatment? A nurse is caring for a client with cirrhosis and notes new onset confusion and a flapping tremor of the hands. Asterixis. What medication does the nurse anticipate administering? A. Furosemide. B. Lactulose. C. Albumin. D. Potassium chloride. Wait, what's asterixis? Asterixis unders flapping tremor of the hands, a sign of high ammonia levels in the brain, hepatic encephalopathy. Correct answer: B. Lactulose. Why? Lactulose traps ammonia in the gut, helping excrete it through stool. Ammonia buildup causes confusion, asterixis, and coma. Why not the other choices? A. Furosemide. Helps with fluid overload, not ammonia. C. Albumin helps ascites, not hepatic encephalopathy. D. Potassium chloride, needed for low potassium but doesn't fix high ammonia. Key takeaway: if a cirrhosis patient is confused, plus has asterixis, give lactulose to remove excess ammonia. Question 33. Addison's disease. What's a big mistake? A nurse is teaching a client with Addison's disease about emergency management. Which statement by the client requires further teaching? A. I should increase my steroid dose when I'm sick. B. I should avoid high-sodium foods. C. I need to carry an emergency steroid injection. D. I should wear a medical alert bracelet. Think about it. Addison's equals low cortisol and aldosterone. So, what's the number one risk? Adrenal crisis. Correct answer: B. I should avoid high-sodium foods. Why is this wrong? Addison's clients need extra sodium, especially during stress or illness. Why not the other choices? A. Increasing steroids? Correct. Prevents adrenal crisis. C. Carrying a steroid injection? Essential for emergencies. D. Wearing a medical bracelet? Helps in case of crisis. Key takeaway: Addison's patients should increase sodium intake during stress, not avoid it. Question 34. DKA and potassium. What's the emergency? A client in diabetic ketoacidosis, DKA, has a blood glucose of 620 milligrams per deciliter and is receiving an insulin drip. Which lab value requires immediate intervention? A. Serum potassium of 2.9 milliequivalents per litre. B. Blood glucose of 300 milligrams per deciliter. C. Urine output of 40 millilitres per hour. D. Bicarbonate level of 18 milliequivalents per litre. So why potassium? When insulin is given, it pushes potassium into the cells, dropping blood levels dangerously low. Correct answer: A. Serum potassium of 2.9 milliequivalents per litre. Why? If potassium is less than 3.3, stop the insulin and give K+ first. Severe hyperkalemia equals deadly arrhythmias. Why not the other choices? B. Blood glucose 300, expected as insulin works. C. Urine output 40 millilitres per hour. Normal. D. Bicarb 18. Low, but not the priority over potassium. Key takeaway: in DKA, always check potassium before giving insulin. Low K+ can be fatal. Question 35. Post-op complication. Is it a PE? A nurse is caring for a post-op client who suddenly develops chest pain, tachycardia, and dyspnea. What is the priority action? A. Administer morphine. B. Perform a Valsalva maneuver. C. Apply oxygen. D. Encourage deep breathing and coughing. Is this a heart attack? No, it's a pulmonary embolism, PE. Post-op clients are at high risk for blood clots. Correct answer: C. Apply oxygen. Why? PE blocks blood flow to the lungs, causing hypoxia. Oxygen helps immediately. Next step: call the provider, prepare for heparin. Why not the other choices? A. Morphine, helps pain but doesn't fix oxygenation. B. Valsalva, used for arrhythmias, not PE. D. Deep breathing, good for pneumonia but won't fix a PE. Key takeaway: post-op clients plus sudden chest pain? Think PE. Apply oxygen, then notify the provider. Question 36. Guillain-Barré syndrome. What's the biggest risk? A nurse is caring for a client with Guillain-Barré syndrome, GBS. What is the most serious complication to monitor for? A. Severe muscle pain. B. Loss of deep tendon reflexes. C. Respiratory failure. D. Urinary retention. Wait, what's GBS again? GBS is an autoimmune disorder that causes ascending paralysis. So, what happens when paralysis reaches the diaphragm? Correct answer: C. Respiratory failure. Why? Paralysis can reach the respiratory muscles, leading to difficulty breathing. This can happen quickly. Always monitor respiratory effort and oxygen levels. Why not the other choices? A. Severe muscle pain, common but not life-threatening. B. Loss of reflexes, expected but not a priority. D. Urinary retention, happens in GBS but not as critical as breathing. Key takeaway: if a GBS patient starts having breathing issues, intubation may be needed ASAP. Question 37. SIADH. Is the treatment working? A client with SIADH, syndrome of inappropriate antidiuretic hormone, is receiving treatment. Which finding indicates that the treatment is effective? A. Serum sodium increases to 135 milliequivalents per litre. B. Urine output decreases. C. Weight gain of 3 pounds in 24 hours. D. Urine-specific gravity increases to 1.035. SIADH, what's the problem here? SIADH equals too much ADH. The body holds onto water, causing hyponatremia, low sodium. Correct answer: A. Serum sodium increases to 135 milliequivalents per litre. Why? A rising sodium level. Shashing treatment is working. SIADH causes dilutional hyponatremia, so fixing sodium means the patient is improving. Why not the other choices? B. Urine output decreases. No, urine output should increase as excess water is removed. C. Weight gain. Weight should decrease with treatment. D. Urine-specific gravity increases. SIADH causes concentrated urine, but treatment should make urine more dilute. Key takeaway: SIADH equals fluid overload plus low sodium. If sodium is rising, treatment is working. Question 38. Post-thyroidectomy. Is this an emergency? A nurse is assessing a client who is post-op from a thyroidectomy. Which finding is most concerning? A. Hoarseness and sore throat. B. Mild difficulty swallowing. C. Tingling around the mouth and fingers. D. Neck pain at the incision site. What's the biggest post-op risk? Post-thyroidectomy, there's a risk of accidental parathyroid removal, leading to hypercalcemia, low calcium levels. Correct answer. C. Tingling around the mouth and fingers. Why? Tingling equals early sign of hypercalcemia. Severe hypercalcemia, tetany. Life-threatening laryngospasms. Immediate intervention equals IV calcium gluconate. Why not the other choices? A. Hoarseness. Expected due to laryngeal nerve irritation. B. Mild swallowing issues. Normal for a few days post-op. D. Neck pain. Expected at the incision site. Key takeaway. Post-thyroidectomy? Monitor for tingling and spasms. It's a sign of dangerous hypercalcemia. Question 39. Nitroglycerin. What's the big mistake? A nurse is educating a client on the use of nitroglycerin, NTG, for angina. Which statement by the client requires further teaching? A. I should take 1 tablet at the first sign of chest pain. B. If my chest pain doesn't improve after 3 tablets, I should call 911. C. I should store my nitroglycerin in a dry, dark place. D. I should swallow the tablet whole with a glass of water. Nitroglycerin equals quick action. NTG dilates blood vessels, improving oxygen delivery to the heart. Correct answer. D. I should swallow the tablet whole with a glass of water. Why? NTG is given sublingually, under the tongue, not swallowed. It dissolves quickly, working within minutes. Why not the other choices? A. Taking it for chest pain? Correct. B. Calling 911 after 3 tablets? Correct. If chest pain continues, suspect a heart attack. C. Storing it properly? Correct. Heat, light destroys NTG. Key takeaway. Never swallow nitroglycerin. It must dissolve under the tongue for fast relief. Question 40. Septic shock. Is the patient improving? A client with septic shock is receiving aggressive fluid resuscitation. Which findings suggest that the client is improving? A. Lactate level decreases. B. Blood pressure drops to 80/40 millimeters of mercury. C. Urine output remains at 10 milliliters per hour. D. Skin becomes cool and mottled. Septic shock, that's bad news. Sepsis equals massive infection, low blood pressure, poor perfusion. Correct answer. A. Lactate level decreases. Why? Lactate is a marker of tissue oxygenation. A decreasing lactate means tissues are getting more oxygen, just improvement. Why not the other choices? B. BP dropping. Bad means worsening shock. C. Urine output. Low. Bad. Kidneys are still failing. D. Cool, mottled skin. Bad means poor circulation. Key takeaway. Septic shock treatment is working if lactate is dropping and BP is rising. Boom! You just tackled some of the most frequently asked NCLEX questions of 2024. But don't stop here. The NCLEX is testing these types of questions over and over again, and I've got even more coming your way. So, if you want to make sure you pass on the first try, hit that like and subscribe button and turn on notifications. We drop new high-yield NCLEX questions every week, straight from the 2024 exam trends.